I have also taught in universities in Kyrgyzstan, Tajikistan, Kazakhstan, and Russia. But this is a new and unique thing, and we all are actually going through a new and unique phase in our life. All of us are right now locked down, and mostly all the schools, colleges, exams, everything are getting postponed. Many institutions are right now coming on this online platform, and many faculties are taking this kind of online classes. But students and friends, this particular platform is a little bit different. Here, at real time, you can see your faculty. You can see this is real time. It is 13th May 2020. And not only that, it is also two-way because you can catch me via live section. In your app, if you look at your mobile, just below the video, there is this chat box wherein the enter your query portion, you can enter your query. I shall get that and that will come to me and I shall give reply to you. Now regarding physiology, recently MCI has come up with a new guidelines where a lot of integrations are talk of the town. There are horizontal integration, there are vertical integration, and all together, for the long time we had this idea that physiology should not be confined, or anatomy should not be confined within four walls of the medical college. It should be connected to the bedside clinics. Like biochemistry should be connected to real life scenarios. And this year onwards, MCI has done that Herculean task. They have integrated almost all the medical subjects so thoroughly, so beautifully. Now, before we move on to this actual thing, let me discuss a little bit of what you should expect in your journey of MBBS. Remember, if you just mug up various texts of physiology or anatomy, you will only be able, if at all, to pass the exam. But if you have to apply that knowledge in your bedside clinics, only knowledge from a single subject will never be sufficient. You need to integrate your knowledge, you need to apply that on day-to-day things. Like we have an idea that we shall start today with serious physiology, cardiovascular physiology. And if a student, however good she is or he is, he learns everything of heart, he marks everything of heart physiology, heart anatomy, but cannot apply in real life, he or she cannot be a good doctor. So here comes the importance of integration. Students, there are two kinds of integration these days Medical Council of India are highly fond of, and they are preaching it. And almost all the universities are given the guidelines of this integration. One is vertical integration, where particular subjects of first year, second year, third year, fourth year should be combined. That means concept should be built like a ladder-like fashion. Your knowledge of physiology will give you the idea of deviation from physiology, which is actually pathology. And deviation of physiology at a particular point will give you the idea of target of pharmacology. And when you combine all these three, you come to medicine, general medicine or internal medicine. So this is the integration in a vertical function. At the same time, we have a lot of options, a lot of opportunities to connect the subject horizontally. That means in a square platform. That means suppose you are reading anatomy of heart and you are correlating the anatomy of heart to the function of heart, which is depicted in physiology. So in this way, in first year subject, two subject concepts driven from two subjects are coordinated. That is known as horizontal coordination. So horizontal integration. So these things are important before you move on. Now, most of the students have already passed 6 to 8 months in their curriculum first Prof, and in some places cardiovascular physiology are already done. Some of the students were not very keen to understand the concept. There are certain concepts that you cannot understand by yourself. You must need the help of a mentor. There are certain questions which you which you can't get answer properly and swiftly from your faculty in your college, because it is a busy class where 150 students are under a particular faculty. So all these things can be cleared over here. We shall go in a particularly comprehensive way. We shall go in an integrative way, so that suppose I am talking about SA node, AV node, at the same time I will integrate with the clinical aspect of it, the blocks, the pacemaker, so that at the end of the year you have a solid basic idea of cardiovascular physiology and the scope of disease and scope of treatment to those diseases. So everything will be ready. And not only that, we know different students have different kind of speed to integrate things. Suppose some parts you know very well, some other parts are known by your friends very well. What I try to mean over here, that all of us have certain strengths and weaknesses. And sometimes we feel a little bit shy to open up, to expose our weaknesses in front of others. Now here also this app will come very handy, where you can, ask question directly to my chat box. After the session is over or during breaks, I will go through all those things and I will individually try to answer. Or if I get a common question, in that case, I will discuss it on the app itself, so that many students simultaneously, all the students can look for it. Few more interesting part regarding physiology. I have been teaching since last 7 to 8 years, and I have been in direct contact of 16 to 18,000 rough estimate of students in India, in West Bengal, and in various parts of various other states in India, and in outside India, where Indian students go to learn medicine, like China, Russia, Kazakhstan, Kyrgyzstan, Nepal. Yeah. So most of the time I see some of the students do carry some kind of misconception that and physiology, anatomy and biochemistry, physiology we have learned during our class 11, class 12, that means class 1, class 2. So we don't need to learn a lot of time. We should skew our time towards anatomy more. So many things, so much pressure, so many items, so many exams. My God, the dead body can have a fabulous smell inside the morgue. Everything just jeopardize our ideas. But remember one thing: 5 years down the line, 6 years down the line, 8 years, 10 years down the line, you will no more be a student. You will become a practicing doctor. And at that time, your knowledge of physiology will be of utmost interest, utmost importance, if you wish to diagnose diseases perfectly, smoothly, and to decrease irrational prescription. Because if you can pinpoint your idea, if you can pinpoint where the disease means the deviation from normal physiology, you will not unnecessarily prescribe vitamin 1, vitamin 2, vitamin 3, vitamin 4. You will never do that. You will never do antibiotic 1, 2, 3, 4. One antibiotic from chest, one another antibiotic from respiratory tract, another for the heart, another for musculoskeletal system. This will never occur. You will be much more pinpointed. The total healthcare cost will come down. Your patient will love you, because much more effect and less side effect will be there. To become a very successful practitioner, you must have a fantastic concept of physiology. Now, coming back to today's condition, today's date. Today or in next 6 months, 5 months, before first Prof, you will have to learn a lot of physiology. You are already in the learning process. Last 6 months, 8 months, you are already learning. Before this COVID crisis, you were going to the colleges. Actual offline learning was there. Now, most of the people, we are shifting it to online learning, basically. So, lot of information you will have to mug up. So there will be a lot of informational storm, a typhoon. It will always disturb your brain. And after a period of time, couple of months, 1 year, couple of years, if you simply mug information inside, guarantee that you will not remember a single thing of physiology after 2 years or 3 years. Here comes the importance of concept. If you have a solid concept of cardiovascular physiology, say for instance renal physiology, neurovascular physiology, then 4 years down the line, when you go and stand in internal medicine exam, exactly examining a patient for his neurological deficit under severe pressure in front of your colleagues, senior, and the deadliest examiner, only your concept will keep you afloat. If you try to remember everything, if you try to mug up everything, you will never be successful. And not only that, your life will be under severe stress. So in a way, I must say that COVID situation that we are going through right now, take this situation as a boon in disguise. Utilize this situation as much as possible, because never before no medical colleges in the history have ever allowed a student to stay at home and read, study, and even after that those studies will be officially counted. Never ever before it happened. Now there's a chance. Take this chance. We are actually going to take this for a long period. Weekly, every week we shall come up with individual subjects, and we will keep the time in this evening hours, 8 to 10 p.m. preferably, so that even after this lockdown period is over, you will still be able, from your Android device or for your tablet, for your laptop, to access all the teaching, all the study, interactive didactic lessons you can get. You can ask the faculty, and all the faculties have variable idea about the whole system, and almost all the faculties are top notch because they have huge experience, not only in their state, not only in their medical college, but in the national system, in variable system, in FMG, National PG, NEET PG, in DNB examination, NEET PG, SS super specialty, and for outside universities also. So students, this will be my honest request. Go through the classes, go through the study materials, take this as an opportunity to learn, to grow, and to do work in a smart and effective way, so that you pass MBBS easily, without not a big amount of stress, and you learn to assimilate knowledge, integrate knowledge, learn good amount of physiology, so that next year when it comes to pathology, your life becomes easy. Many of us in our days, this kind of apps were not there. We had to struggle very hard. We had big textbooks, and most of the textbooks are heavier as dumbbell. They were better for exercising rather than reading. So those days, initially we could not find the right and smartest way. We had to toil hard, 8 hours to 12 hours for physio, anatomy, and biochem. And then again, when we go to pathology, we have just forgotten what we learned in physiology. Again, we need to learn from the basics. For first 1 month, we have to learn physiology. Then only we start understanding pathology. But now, thanks to Medical Council of India, thanks to the newer technologies, we are at a very crucial junction. Now we can integrate knowledge. Now we can ease our life. So with this introduction, we will also come to this basic ideas, side ideas time to time. But with this introduction, we shall start today from cardiovascular physiology. And we got the request of cardiovascular physiology from many corners, basically, and it is also the very basic. 50 to 60% of students know cardiovascular physiology by now, so it will be helpful for them to to repair all the dents in their knowledge. And a minority of students, maybe 30% or 40%, they do not have that good grip on cardiovascular physiology. And trust me, if properly exam is taken and a properly difficult paper is set, it will be proved 100% of students do not have enough knowledge in cardiovascular physiology to pass if properly viva is taken. But I pray to God that he shows some mercy to you. Anyway, so we shall start with cardiovascular physiology, and we shall go a little bit slow since this is the first class, and with time we all will be better known to each other, our style will be known to each other, our speed will be known to each other, and then it will be easier for us to maintain a harmonious speed. So regarding cardiovascular physiology, first what we need to know is the heart, and this is the functional anatomy of heart. So this is very important. Anatomically, the people who knows thorax, anatomically there are 4 chambers of heart. So first I shall draw these 4 chambers of heart over here. Remember, this is a schematic diagram, but this diagram you must keep in your mind throughout your life. Here you will get a lot of ideas about everything what you need to remember. So this is a schematic diagram basically. So I'm not using color coding, I'm just keeping black and white in the initial part to just give you the concept and schematics. So by this time there are 4 chambers in heart. This is left atria, this is left ventricle, this is right ventricle, and this is right atria. Now this is in between this is the interventricular septum. So we call it septum. Okay, so this is the septum. Now left atria, it has some connection through which blood actually comes into left atria, and these are known as pulmonary veins. Always remember, and you need to remember also the direction of blood flow. So this is pulmonary veins. So through pulmonary veins, actually what happens? Oxygenated blood that comes into the left atria. That again something of noting, because this is an exception. We are calling it veins, and oxygenated blood is coming through veins, but we will come to that later. Now in between left atria and left ventricle we have a pair of valves, and these valves are known as bicuspid valve or mitral valve. Why bicuspid valve? Because this valve has 2 cusps. So this is known as bicuspid valve. Now then we have this valve also is connected with chordae tendineae, which connects it to the papillary muscle, but I am not right now giving the diagram or right now drawing chordae tendineae over here, for it will become more clumsy in later drawings. We shall do that. Then we have left ventricle, and left ventricle is drained into one structure, and the name of that structure is aorta. So this what we have, this is aorta. So left ventricle is drained into aorta. So this is aorta. So from where aorta starts? Aorta starts from here. Aorta starts from here. And there is one pair of valves here, and this valve is known as semilunar valves. These valves are known as semilunar valves. And semilunar valve, since it is on the aortic side, so it is known as aortic valve. Okay, this is the aortic valve. So this is the left side, and now we come to the right side. We have to look on the right atria. Right atria has 2 connection. One is on the top, and this is known as SVC, superior vena cava, and another in the bottom, this is known as IVC, inferior vena cava. Now superior vena cava and inferior vena cava, through this vein, these are the great veins through which actually deoxygenated blood enters into right atrium, and deoxygenated blood then goes to right ventricle from right atrium through a channel or through a valve system, and this valve system is known as tricuspid valve. this valve system is known as tricuspid valve. So you know now that right atria and right ventricle is connected by tricuspid valve, and right ventricle then goes and drains into pulmonary trunk, PT, pulmonary trunk, which is pulmonary artery basically. So we call it pulmonary trunk, and pulmonary trunk, in between right ventricle and pulmonary trunk, there is, one pair of valves, and these are known as, again, these are also semilunar valves. These are semilunar valves. So which semilunar valve? These are the pulmonary valve. Pulmonary valve. So if you look at, so I think you can see that, these are the pulmonary valve. If you just write pulmonary valve, that will be sufficient. Now, if you look at the whole system, for everybody, just remember, by heart you should know, oxygenated blood is coming through pulmonary veins. From where actually they are coming? They are coming from lungs. Okay. And then it goes to left ventricle during its diastole. So left ventricle receives blood during left ventricular diastole. Remember, in all books all over the world, if they mention systole or if they mention diastole, they are talking about left ventricular systole or left ventricular diastole. That is the dictum. Now you may ask me that how to tell whether it is left atrial diastole or right ventricular diastole or left atrial systole or right atrial systole. Then you need to mention left atria, right ventricle as a prefix. That means you need to mention their name, the name of the chamber before the phase of the cardiac cycle, systole or diastole. Only then it will be done. Otherwise, all over the world, it is a dictum. Always remember, in ECG, in echocardiography, in cardiac MRI, in cardiac CT, whatever way it is, in your class, in your exam, in clinical exam, in patient care, whatever way it is, if there is systole, it means left ventricular systole. If there is diastole, it means right ventricular diastole, left ventricular diastole. And all other chambers events should be written in such a way that the name of the chamber must be written before the phase, systole or diastole, right ventricular systole of left ventricle, like that. Okay. Now where were we? We were at the blood flow. So blood comes from lungs, oxygenated blood that goes to left atria, then through this it goes into left ventricle, from there through this it goes into aorta, from aorta actually it goes to all parts of body. Basically here cardiac output is generated, which creates blood flow, extrinsic blood flow to all other parts of body, different body systems. Okay. And on right side, deoxygenated blood comes, and deoxygenated blood comes, and it goes through SVC and IVC, and then it is inside the right atria, and from there it goes into right ventricle. From there it goes to pulmonary trunk, which again, remember, pulmonary trunk, again it is draining into lungs. Basically from right-sided heart, deoxygenated blood goes to lungs, where it receives oxygen to become oxygenated blood, and that blood is supplied to left-sided heart through pulmonary veins. So basically, one more important issue is physiologically, if we look at physiologically, only two hearts are present. Physiologically, two hearts are present. One is right heart and the other is left heart. Whereas anatomically, these are the only two divisions. Anatomically, there are four divisions, four chambers. Those are structural divisions. These are functional division. Understand? And some of the colleges, in some cases, you may face this in viva or practical. This idea that physiologically 2 divisions, anatomically 4 divisions, structural divisions, and number 4. So before we move on to this cardiovascular physiology, a little bit more knowledge we need to know, because if we just jump over here, there is a chance that we will never come back to this. So first, here we need to have an idea between various kinds of circulation. So here the people who are taking notes, for them also it will be easy. There are 2 circulation which I shall explain right now in a tabular form. This is systemic circulation and the other is the pulmonary circulation. So these 2 important circulation. Just remember, it is in the concept is in the context of the previous discussion, where we have discussed that deoxygenated goes to lungs and oxygenated comes back from lungs. So we are there actually. Okay, so systemic circulation, this is the circulation, you see the direction, heart to systems. Systems mean GI system can be, nervous system can be, renal system can be, musculoskeletal system can be. So heart to systems and back to heart. This is the systemic circulation. Pulmonary circulation, it's a little different. It is heart to lungs, purification, processing, and back to lungs, back to heart. This is pulmonary circulation. So first difference is this. Second, systemic circulation. The laws of physics are different in systemic circulation. The physicality of systemic circulation and pulmonary circulation are different. Systemic circulation, it is high resistance. Resistance is very high. Why? Because in most of the vessels in systemic circulation, vascular smooth muscle, highly beautifully built up vascular smooth muscles are present. Plus, systemic circulation vessels are long, one after another, in the series connection, and Ohm's law told us series connection resistance will be high. Now, high resistance means low capacitance. You can remember from Ohm's law, low capacitance. In terms of vessel capacitance, this denotes volume, adaptability. So low capacitance, it's not electrical capacitance we are talking about. So low capacitance and high resistance will lead to high pressure in systemic circulation. This is about systemic circulation. On the other hand, in case of pulmonary circulation, there is low resistance, okay, high capacitance, and low pressure. So low resistance, high capacitance, low pressure. Okay, I think you can see it now. Resistance and capacitance, I have used just the short form because of the space issue. Now, how much pressure is high? How much pressure is low? So if I ask you what is a normal blood pressure, most of you can answer. That is this. Actually, probably none of us have this. We might have 124 by 84, might have 130 by 70, 90 by 60. That means that's a range. It's not like that this particular value is normal and everyone else is a liar. Just like our, nowadays situation is just like that. If you don't follow my idea, my way or highway, kind of. No, it's not like that. It's a range. It's simply a range. 120 by 8 is the mean over there. And this obviously bears a, unit, that is millimeter of mercury, and that is the value, mean or average value of systemic circulation. You see, that is the average value of the systemic circulation. Pulmonary, much less. I have just mentioned there will be low pressure. How low? How much low? Yes, pulmonary is 15 by 0. My goodness, so low? Yes, it is so low. Why? Because, first of all, vascular smooth muscle, the vessel walls are thin and Millions of capillaries are in parallel circuit in pulmonary system. So it decreases the resistance many fold. So it comes down to 15/0 under normal situation. Definitely there is one entity called pulmonary hypertension where pressure increases. Pressure can go up to 35, 34, 40, then we will call it pulmonary high BP. But that is out of the syllabus, at least on your first year. You just remember that yes, there is something called pulmonary hypertension, pulmonary high BP, which is definitely something different from systemic high BP. Normally what we know as BP is basically systemic BP we discuss about. In hypertension, if someone has hypertension, then it is actually systemic hypertension we generally talk about, but pulmonary hypertension is also a very important phenomenon. And the last thing in systemic circulation, that here in systemic circulation, these arteries carry oxygenated blood, whereas veins, they carry deoxygenated blood. In pulmonary circuit, the situation is opposite, where arteries carry carbon dioxide rich blood, deoxygenated blood, and veins carry oxygenated blood. Can you tell me there is another system in our body where this reversal happens? And yes, that is umbilical system. Remember, this is again an MCQ, that umbilical artery that carry deoxygenated blood, umbilical system that connects mother to fetus. It carries carbon dioxide rich enriched blood, and umbilical veins, it carries oxygenated blood. This is important. Just for your information, keep in mind and grab the concept, and let's move on to our next important topic, that is cardiac cycle. So cardiac cycle, this is extremely important. As a long question it can come, as a short note it can come, partially it can come. People will definitely ask you in Viva about cardiac cycle. To understand and answer to various short notes, explain why, and other course questions, you have to know cardiac cycle. If you don't know cardiac cycle, you are not eligible to become a doctor. You can simply kill the patient easily if you don't have the idea of cardiac cycle sealed inside your heart. Okay, so what is cardiac cycle? It's the cyclical events that takes place in heart from one beat to another beat. In other words, you can read various textbooks. Fantastic definitions are there. The basic idea is cyclical events that take place in heart from one phase to another phase. And remember, one cardiac cycle in this way is comprised of one systole and one diastole. Okay, systole means the contraction, diastole means the relaxation. Again, you remember, just now I told that if I say systole, it means left ventricular systole. If I say diastole, it means left ventricular diastole. And all other chambers we have to know in comparison to this, in the context of this. And in all other chambers cases, you have to mention the name of the chamber before that. Okay, now cardiac cycle. Now can anybody tell me that how many times heart beats in a minute on an average? We know it from class 5, class 6, and yes, that's correct. It's 72. 72 times it actually beats in a minute. So 72 cycles happen in 60 seconds on an average. So each cycle duration will be 60 by 72. It is 0.8 second. Again, important for MCQ. Remember, students, I sometimes use this kind of symbol like Q. Q means these are very important for MCQ, like that. So 72 times heartbeat, 72 total cardiac cycle occurs in a minute if the heart rate is 72, and then individual cycle duration will be 72 by a minute, means 72 by 60, that many seconds comes down to 0.8 seconds. Understand? Okay. Now, out of which you must remember the duration of individual chambers, which is extremely important for I can see if there are certain students who have joined from outside India. That means you are FMG candidates, and also in HPG or exam, the duration is asked of for individual chamber. So of this, atrial systole is 0.1 second. Atrial systole is 0.1 second. Atrial diastole, definitely it will be 0.8 minus 0.1, so it will be 0.7 second. Atrial diastole, let me make it a little bit more visible. Yeah, so atrial diastole is 0.7 second. Ventricular systole, this is 0.3 second. Ventricular diastole, it is 0.5 second. So all this, just put a Q over there. This is important for MCQ and for Viva. And apart from that, we will move on. But before that, you need to look upon certain things. If you look at, you see diastole in atria 0.7 second, much higher than systole. And diastole in ventricle is still higher than systole, that is 0.5 second. That means the whole cardiac system, whole cardiovascular system, in terms of time, in terms of duration, for a longer duration, it stays in diastole than systole. Remember, for a longer duration, it stays in diastole than systole. Okay? So with this, we shall move into cardiac cycle proper. Now, it's a cycle. And we shall actually in this class or in your physiology examination, one more thing that I need to tell you, that sometimes students come and ask us, sir, how we shall proceed, how we shall write in exams, because in our schools we have to answer long questions, then during our NEET UG you have to answer MCQs, and again suddenly we have come over here where there is a mixture of different questions. We also have to face number one question, we also have to face 10 marks, 20 marks, 12 marks depending on the various universities, 3 marks short note, explain why. So how we should actually proceed. Plus sometimes papers are very long, pretty long papers, and in those scenario you just can't waste too much of time by writing essay, because suppose a question has come to you with a mark 10 and you have written 40 pages on that, and then you have another 40 marks to complete, and you just have maybe 15 minutes for that. So at the end of the day you might get a Nobel Prize for that 40 pages thesis, but you can't pass MBBS exam. But our course, our main aim is passing you, helping you pass the MBBS exam. Once you pass it, you become a scientist, you do whatever you wish, you 40,000 page or 4 lakh page thesis you write. But for exam you must be much more methodical, because sometimes you remember, sometimes you must understand that if you are skewed, your ideas are skewed means some chapters 1 to 5 you do not know anything, but chapter 5 to 10 you know too much, you know even better than me. That will not help you passing the exam. You must have a balanced system. Similarly, all the questions you must be balanced. Okay, might be in some questions you might be 10% better but do not waste too much time answering one particular question. It's a very common mistake. Even I, in my years, in my initial UG years, I was also a victim to this. There were so many times I have missed, or I thought that last few questions I could have answered much better had I not waste too much of time in question 1 or question 2. So this happens. So here you need to know the art of giving exam, art of writing exam. Yes, definitely you must have to have the knowledge, but that is not the only criteria. There is something. See, examiners will give you marks if you know the thing, if you can show the thing, and if you can distribute the thing in such a way, in a very typical manner, because all the examiners are busy people. They don't have any interest, whatever essay, whatever you might even invent the vaccine for COVID, but examiners don't give a shit to it. Basically, they want to know, they want to see the important points, they want to see the coherence of thoughts. So the best way to demonstrate that is you write the major events as a sentence, use an arrow, go to the next sequence of events. And this kind of question, like cardiac cycle, where we are discussing about the events, in this kind of scenario, this is the best approach to do. Suppose the way, now I shall also demonstrate the whole cardiac cycle in the light of this, and you will get an idea. I am not asking you to copy me blindly, but you can see it, make it in your own way, and utilize in all other questions of physiology, and not only all others possible questions of physiology, but also in other subjects in first year and later on also. So we are coming to the cardiac cycle. Now it's a cycle. Since a cycle, it's a circular thing, so we can start from any point, but for our better understanding, I am starting from the end of diastole. Whose diastole? No need to mention, because I mentioned diastole, means it is left ventricular diastole. And remember, again, some students might have joined later. We are right now doing cardiovascular physiology, and in first Prof Mbbs, heart is a very important thing in your paper 1. And remember that questions from heart, mostly 95% of questions will come from the left heart, and rest will come from the right heart, if at all, 5% or so. So left heart you have to understand very well this time. Okay, so we are starting cardiac cycle. We are starting at a point which is at the end of diastole. Remember, at the same time, I am also demonstrating my way, preferred way of writing a question answer. Because understand, most of the examiners, they are very busy people. They only want to see the points. If you write those points sequentially, if you can make them understand that you understand, that's enough. Do not write write an essay. Don't make your examiner search for the answer. Display it. Display it just as a show business person. Display, that's all. Least effort, least friction, best marks. Okay. So at the end of the diastole. Diastole means left ventricular diastole. Diastole means blood will move into left ventricle, because diastole means relaxation. Now, as the end of left ventricular diastole happens, that means left ventricle contains maximum amount of blood. So left ventricle now has maximum volume of blood. Diastole has ended. Means what? Means valves are closed. Which valve? Mitral valve. Because in diastole, left ventricle receives blood. From where? Left atria. Through which valve? Mitral valve. Now mitral valve is closed. Aortic valve is yet to open. So the whole system has come to a point where aortic plus mitral both are closed. Both are closed. And heart or ventricle is a closed chamber. Now remember, as the ventricle is over, electrically systole will start, contraction will start. because that is independent phenomena. Once the relaxation is over, systole will start. Once the systole is over, diastole will start. That is an independent electrical event, independent of, irrespective of whether your ventricle gets blood, less blood, more blood, no blood, it will still occur. Okay, so systole begins. That is the body programming. Systole must begin. Systole begins means what? Contraction begins. Whose contraction? Contraction of ventricle. Now this is very interesting. Ventricles are being contracted, and at the same time, aortic valve, mitral valve, both are closed, and ventricle is a closed chamber. Now think of the balloon in Holi. You have rubber banded and you have closed it. Now you are compressing it. What will happen? Water is non-compressible, like blood is non-compressible. When you compress a balloon, the shape distorts, volume remains same until and unless it is bursting out. So here also, what happens? Volume remains same, but due to contraction, huge pressure is being generated. Pressure is high. Whose pressure? Left ventricular pressure. Left ventricular pressure is high. So we get a condition where ventricle is a closed chamber. Where we are? At the end of diastole and systole is begin. Ventricle is a closed chamber. Volume remains same, but due to contraction, LVP is increasing. So we are now at a phase which is known as isovolumetric contraction. Isovolumetric contraction. So in this isovolumetric contraction, what happens? LVP rise, volume same. Now as isovolumetric contraction continues, what will happen? Left ventricular pressure becomes greater than aortic pressure. This is important. So what will be the relation of left ventricular pressure and left atrial pressure? Definitely left ventricular pressure is greater than left atrial pressure to 2. But mitral valve being an unidirectional valvular system, blood cannot flow back. On the contrary, here aortic valve still unidirectional, but on the opposite side it opens towards the aorta. So as left ventricular pressure is too high, so then we come to a situation when aortic valve opens. As aortic valve opens, at this point, the pressure gradient between left ventricle and aorta is very high. So there will be rapid flow of blood from ventricle to aorta. Since it is rapid flow of blood from ventricle to aorta, we call it, this phase is known as rapid ejection period. This phase is known as rapid ejection period. So two periods we have come right now. One is isovolumetric contraction. The other one is rapid ejection period. Okay. Now once rapid ejection period is continuous, what is happening? Systole is on, it is increasing the pressure, but due to systole and opened up aortic valve, pressure is also being released. So blood is going away from ventricle. So a time has come when the gradient LVP and aortic pressure gradient is a little smaller. So at the end of rapid ejection period, we get a situation where LVP is greater than aortic pressure. Remember, here it was greater than, and now here it is just greater than aortic pressure. So flow will still continue from LV to aorta, but at a much slower phase. So this will be known as slow ejection phase. Okay, so I think you can understand this. And once this is done, once this slow ejection phase continues, a time will come when, you see, when LVP will be equal to aortic pressure. What will happen? LVP is equal to aortic pressure. What will happen? Will it stop? Can you stop a car? Suppose you were driving a car at 80 kilometers per hour. Somebody just come in front of you, or somebody just, wave a hand and ask you to stop. Can you stop it? Then and there? You can't, because there is inertia. So you have to develop a lot of friction to overcome that inertia. That is the scenario here. LVP remains equal to aortic pressure, but still blood flow, definitely at a slow rate, continues from left ventricle to aorta due to inertia. D by T due to inertia. And we call this phase protodiastole. Now what will happen? Now it will be a negative pressure. So now the whole thing will come to this. LVP will be lesser than aortic pressure. After this protodiastole, LVP will be lesser than aortic pressure. Then what will happen? Aortic pressure will close down the aortic valve. So this will lead to aortic valve closure, because pressure above is high, pressure below is low. So aortic valve closure. And as aortic valve closes, LV to aorta blood flow stops. So this is the end of systole. Apart from this, one more thing I wish all of you to remember: this aortic valve closure. Aortic valve closure. This has a particular implication. This leads to generation of a sound, and that is the S2 or second heart sound. Here, just for the information, we need to remember S2 or the second heart sound. That is due to aortic valve closure. Remember, so aortic valve closure leads to development of S2 or second heart sound. End of systole. Now beginning of diastole. That's an electrical event. So as systole has ended, diastole has to be started. So let's go to that. How? So at the end of systole, situation is again the same. Again, ventricle is a closed chamber. Ventricle, because mitral is closed, aortic is closed. That's the scenario. Now what will happen? Diastole begins. Means what? Means relaxation begins. Whose relaxation? Ventricle. So as relaxation begins, what will happen? LVP, left ventricular pressure, will fall down. But left ventricle is a closed chamber. Volume in a closed chamber will remain equal. So now we get one situation, which is the first situation in diastole, that is relaxation keeping the volume same, volumetric relaxation. That's the scenario. Now after this isovolumetric relaxation, as this continues to happen, what will happen? Left ventricular pressure falls and falls and falls, and a time comes when left ventricular pressure becomes lesser than left atrial pressure. It is also lesser than aortic pressure, but semilunar valves are unidirectional. They cannot open towards the ventricle, so no question of any backflow under normal scenario. What happens? Come back over here. left ventricular pressure is lesser than left atrial pressure. And as it is lesser than left atrial pressure, blood flow starts from left atria to left ventricle through mitral valve. So blood flow starts from left atria to left ventricle through mitral. A means mitral valve. Remember, again look, this is lesser than, means the pressure gradient is very high. That's why this is lesser than, right? So as the pressure gradient is very high, blood flow, inward blood flow will be very fast. So this phase will be known as rapid filling phase. Remember, since after 2 minutes, 3 minutes, 4 minutes, you will come to know that there are two rapid phases. So here in diastole, this phase is known as first rapid filling phase. After that, what happens? As the rapid filling phase continues, the gradient, pressure gradient between LVP and LAP, that actually falls. The pressure difference falls. That will lead to sluggish inward blood flow. That will lead to sluggish inward blood flow. And this phase is known as diastasis. Stasis means stoppage. Stasis means stoppage. So diastasis means it seems like that the diastole is stopped. That kind of a thing. Diastasis means seems like diastole is stopped. Okay. Now we are coming to the next part. After diastasis, what starts? Atrial systole starts. So far, whatever was happening was due to ventricular suction. Remember, during ventricular diastole, left ventricular diastole, initial 75% of blood inflow is due to ventricular suction. That means ventricle is relaxing, getting bigger, creating volume, sucking blood in. Last 25% is due to atrial push. Left atria, from there it pushes. So blood goes into ventricle. So initial 75% is due to ventricular work. Last 25% is due to atrial work. And now we have just post diastasis, we have come to the last 25%, and now atrial contraction happens, atrial systole happens, and due to atrial systole, left atrial pressure becomes greater than LVP, opposite way. And now again there is a rapid flow of blood from A to V. And this is known as rapid filling phase. This is known as rapid filling phase. But already there is one rapid filling phase. So this is second rapid filling phase. So remember, this cardiac cycle or everything in our body where there is some fluid dynamics involved, fluid gas will only pass from one point to another point if there is a pressure difference. A favorable gradient, if it is present, only then it will pass, otherwise it will not pass. So here in the first rapid filling, there was a huge gradient because ventricular pressure was much low. Second rapid filling, there is a huge gradient because though ventricular pressure is low, but here atrial pressure is generated and it is much higher. That's why that is happening. So first rapid, second rapid, so we have come to this. And then one scenario comes when left atrial pressure, atrial contraction actually stops, ventricle is not that, now it has reached its diastolic, last portion. So left atrial pressure is almost equal or less, left ventricular pressure is almost equal or less than left atrial pressure. And at this time, one thing happens, that is mitral valve that closes down. And as mitral valve closes, we can call it end of diastole. We can call it end of diastole. And this end of diastole is also signified by this event. Closure of mitral valves gives rise to one sound, that is S1 or first heart sound. So closure of end of diastole, which happens after mitral valve is closed, that gives rise to this scenario where first heart sound is formed. So this is all about cardiac cycle, and now we shall move on to another important aspect that is very important for your exam, pressure volume loop. But before that, we shall take a small break of 2 to 5 minutes. And meanwhile, you can chat to me, you can ask me questions, and you can also let me know whether you are comfortable with the speed, whether you are liking the class, whether you are liking the methodology, what other things do you want to learn. But it will be too early for you to decide what other things you want to learn, because it's just the first class. So almost everything you wish to learn, and many things you should have been many things you should basically. So rather, my query, you are free to ask anything related, but my query to you will be that you are able to grasp, able to get the sound properly, get the visuals properly, and then able to grasp the concept properly. And in case of any question, I'm free to ask the questions to me. I shall try my best to answer individually. If not, I will at least have a common doubt clearing session so that everybody can have a better concept. So we are taking a small break. We shall be coming within 5 minutes. So after break, everybody, good evening. We have come over here, and now first a little bit of introduction, then we shall again go back to this. So a lot of questions and a lot of comments that have come to me basically. So someone why pressure is, someone has asked why pressure is high in systemic. See, there are a lot of things. Systemic has all the great vessels, and at the same time in systemic circulation things are connected, the vessels are connected in a series connection with higher vascular tone is there, and it is directly getting the cardiac output from heart. Basically the pumping of heart is over there, the excessive vascular resistance is over there because of high vascular smooth muscle tone and high density of vascular smooth muscle. And most of all, there is series connection between the vessels, so that's higher. Whereas on the pulmonary circuit, pulmonary, millions of pulmonary capillaries, they are connected to each other by the parallel circuit, and as per Ohm's law, parallel circuitry decreases the resistance. And pulmonary vessels, pulmonary capillaries, they are also thin walled, and being thin walled, they are offering less resistance to the flow. Now 72 bits, somebody has said, yes, 72 bits, but none of us are right now having 72 bits. I am giving you an explanation, and I'm taking a class. My bits are obviously higher, and since I am not teaching very well, might be some of the students are there who are sleeping right now, so they are having 52 bits, whatever, I don't know. And I don't know, this is a very fantastic medium. I don't know whoever is doing what. Someone might have 50 bits, someone might have 100 bits, or I don't know, someone might have 120 bits or something. So anyway, from where to read CVS, any book? Actually, it was a question, from where to read CVS, question mark, any book, question mark. The answer is that any book, any book. But yes, first of all, there is actually not a single book which will be sufficient for all. Depending on your university, if we talk about Indian universities, if you look at individual university, then individual universities have a little bit individual choices. Um, for an international level, I would say Ganong Gaitan or smaller Ganong, I mean student version, student edition are sufficient. Sambulingam is good. There are other textbooks also depending on that, but we should not um, specifically mention. You can personally contact me. I can give you some personal opinion regarding that. But as of my opinion, foreign books, bigger books like Ganang Gaitan, there's a much more of research value, much more for the PG students. If UG students start reading from that book, again comes to that point that the balance. Because you have to finish three major subjects along with PSM, you have to have a very good grab on your first year, along with so many things that those are happening in your life. So take some book which is crispy, which is good, which is authentic, very important, and which is to the point for the first year exam. Someone has said that you said oxygenated blood enters right atrium. No, that was deoxygenated. Might be there was certain, I think, some kind of communication error. Definitely, deoxygenated blood enters to right atrium and oxygenated enters to left atrium. That's very, common. That's very evident. Um, Systemic circulation resistance. This has come to me many times. Again, series connection, more vascular smooth muscle, thick wall, more vascular contractile force leads to higher resistance, whereas in pulmonary circuit, thin walled vessel, in parallel circuit, as per Ohm's law, low vascular resistance. Sir, doesn't protodiastole come under ventricular diastole? Now, this is very tricky. Some of the books mention it in that. Some of the books mention it in that. Remember, when I mentioned everything, I mentioned in a pressure sensitive way on the basis of pressure, gradient. So protodiastole, where I mentioned, if you write my way, you are correct. No issue with that. Basically, protodiastole means just before diastole. Some of the books include, yes, definitely some of them have included it in diastole, but if you go in this pressure gradient way, it's okay, no issue with that. Which book should we prefer to read? Please prefer to read some books at least. Yeah, the jokes apart. And then any book, any Indian author, whatever, whichever book you take, you read it. You keep your university exam questions. You first complete your university exam questions starting from last year backward up to 10 years and read it thoroughly from that book. If you still have some confusion, you go through our classes, you ask us. If you still have some confusion, and you go to some reference book. If you still have some confusion, keep it over there, because you will still have confusion but no time. Okay, and everything is going perfect, sir. Somebody, some praiseworthy words at least. Okay. Sir, why will mitral valve close when LAP is greater than LVP? Oh my goodness, definitely mitral valve will close when LAP is greater than LVP. This is, suppose this is the mitral valve. This is LA. This is LV. Now, oh no, that was the question. Okay, why LVP? The actual thing is, when was it written like that? Okay. Yeah, there's the mistake actually. Yeah, I'm sorry. This will be LVP greater than LAP, and that will close the mitral valve. Okay, so yes, you are correct. It should be the opposite way. Yeah. Now we are coming to our next part. So that is the pressure volume loop. Pressure volume loop. Now, what is pressure volume loop? It is a pressure volume loop of left ventricle. Pressure volume loop of left ventricle. And don't be too much worried about the word loop. It is nothing but a graph. It's a graph where volume is taken on the x-axis and pressure is taken on the y-axis. So that's the graph, and pressure volume loop will give us the idea of change in volume to change in pressure during systole and diastole in ventricular events. At the same time, all the ventricular events we can plot on this graph, and from this graph we can also know about various disease phases and various changes. So we'll have a long discussion regarding this pressure volume loop. Yeah. So this is like this. Starts from here. Okay, so it's a volume, and then we go up to this, then we go up to this, and then we make it and we come up to this. So this is the pressure volume loop. So we are pointing it with digits 1, 2, 3, 4. Yeah. So this is the pressure volume loop, where you see now we have to put volumes. There's a schematic. So 60 ml is here. It is 130 ml. That's on volume axis. Now we see, yeah. So 60 ml, this is the least volume in terms of pressure volume loop. Now tell me when least volume is present in ventricle. Least volume is present in ventricle at the end of systole. So this is end systolic volume, ESV. 130 ml is the highest volume that is present in ventricle. So when maximum amount of blood present in ventricle, that is during end of diastole. So this is end diastolic volume. So end systolic volume, end diastolic volume. Okay, yeah, now you can see it. Yeah, end diastolic volume. Now you see certain changes are there. We shall explain each part properly. Okay, so if you look to 1 to 2, first you look to 1 to 2, 1 to 2. Okay, that's the scenario. At point 1, you can see the volume is least. Pressure is also least. It's not 0, but pressure is least. And then it is increasing. Increasing slowly, 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 it is increasing. You see, on volume axis, increase is very high. Whereas in pressure axis, increase is much gradual. That is not much increase on pressure axis. So what is actually happening? Volume is increasing, pressure is increasing at a slower rate. And after that, a period comes when increase in volume is stopped. Increase in pressure is very high, 2 to 3. You can see increase in pressure is very high, but there is no increase in volume. So 2 to 3, that's a phase. 2 to 3, that's a phase where volume remains normal, same, pressure increases manifold. So this 2 to 3 is the zone of isovolumetric contraction. Clear? So what is 1 to 2? So 1 to 2 will be just before 2 to 3. We are just coming a little bit back, and from here we shall know what is happening. Isovolumetric contraction is the first part of systole. Okay. Now 1 to 2, that means it is in diastole. Yes, it's in diastole, that's why volume is increasing. So 1 to 2 is the zone of diastole. At the end of diastole, what happens? Mitral valve closes. On the right side, tricuspid valve closes. On the left side, mitral valve closes. On the right side, tricuspid valve closes. So at 2, here one thing's happen, that is mitral valve closure. At 2, there is mitral valve closure. From our last discussion, we got one point that closure of mitral valve will lead to one heart sound, that is S1. So that's the place where S1 actually happens at the end of diastole. Okay. Then isovolumetric contraction continues, and the time comes when left ventricular pressure becomes very high. You see, it's very high. It started from over here, it goes up to here, it is very high, and LVP is greater than aortic pressure. At this point, aortic valve opens. As the aortic valve opens, we denote this place as 3, aortic valve opens. As the aortic valve opens, initially there is gush of blood. You see, volume is decreasing, but pressure is still increasing. So this is the this is the rapid ejection phase. And after that, the gradient becomes a little low. So it becomes the slow ejection phase. Slow ejection phase. After that, that means what is this? This is systole. So 2 to 3 is isovolumetric contraction, 3 to 4 is ejection. So 2 to 4 is systole. So from 2 to 4, this is systole. And at the end of systole, aortic valve closes. So point 4, where systole ends, that's the place where aortic valve closes. An aortic valve closure leads to one sound, that is S2. So 4 is the point where we can get S2. 2 is the point where we can get S1. The similarity between two, that closure of valves causes heart sound. Opening of valves do not cause sound normally. Remember, again in exam, they will ask you, they will test you, they will confuse you on this regard, whether closure causes sound or opening causes sound. Physiologically, if there is some disease, situation will be totally different. Physiologically, whether closure causes sound, opening causes sound, closure of valves causes sound. Closure of mitral causes S1, closure of aortic causes S2, and the right side is a mirror image. So closure of tricuspid causes S1, closure of pulmonary causes S2. So basically we can write S1 is nothing but M1 plus T1, closure of mitral and tricuspid. S2 is A2 and P2. Clear? Now we are again coming back to this, where we are at point 4. Now as aortic valve closure has happened, after that what will happen? After that, you see, pressure is decreasing, volume remains the same, 4 to 1. So this is isovolumetric relaxation. So ladies and gentlemen, 4 to 1 plus 1 to 2, this zone is diastole. Okay. So once again, I shall summarize this pressure volume loop. At the same time, you have the time to draw. Simultaneously, you will listen to what we have discussed over here in pressure volume loop. It's nothing but, it's nothing but the graphical representation of pressure and volume, changes in left ventricle. You can ask me, can we draw a pressure volume loop of right ventricle? Yes, you can draw, but pressure on right side will be low, so the pressure volume, but volume will remain the same. So the pressure volume loop of right ventricle will look, as per shape it will look all the same, but the size, the height will be a little lower, because height is denoted by pressure as per the graph. Now, second thing is that whenever mitral closes, almost at the same time tricuspid closes, at least, which is perceived by our ear. So M1 and T1 occurs almost at the same time. So we perceive M1 and T1 as a single sound. Suppose one sound, then the other sound. If there is a big distance between these two sounds, only then our ear can perceive as it two different sounds. That happens in the case of aortic and pulmonary component of S2 basically. So we'll go to that a little later. And you see, when it comes to 3 to 4, that is systole, that is ejection. It has two phases. One is rapid ejection, the other is the slow ejection. And then 4 to 1, it is aortic valve closure. Then that is a part of diastole. Okay, so far we have understood all this. Now we shall discuss a little bit physiological and clinical significance or applied significance of pressure volume loop. Now some of you are asking me that what is the significance of reading this. The major significance of reading this is this appears in the exam quite regularly and you have to answer it to pass. So first significance. The second significance is that if you know this by heart, you will repeat the knowledge of cardiac cycle. So this will actually enrich your knowledge, enrich your basics of cardiac cycle in a graphical way. So your ideas of cardiac cycle will be much better. And you can also reach to different heart sound like S3, S4, everything from here. Okay. Now we are coming to some clinical aspect of pressure volume loop. So what is the clinical aspect of pressure volume loop? So first of all, this is the normal pressure volume loop that I have drawn, where this is the volume axis, this is the pressure axis. Now you tell me one thing, if end diastolic volume increases, what will be the scenario of this pressure volume loop? You think, take some time, and in 10 to 20 seconds take some time, and then I shall explain. End diastolic volume, if suppose preload, end diastolic volume is equal to preload. If preload is increased, what will be the pressure volume loop? End diastolic volume, if it increase, the pressure volume loop will be shifted towards right because volume will be increased in this scenario. So there will be a right shift. So right shift is actually right shift is actually seen in case of situation where preload is high. But I feel most of you know what preload is. Some of you might have some confusion about preload. So let's discuss preload also in this context, which is extremely important. Preload is a misnomer because it is nothing about load, it's about volume. So preload is the volume of blood that is present in ventricle before systole begins. So basically, before systole begins, whatever volume is present in ventricle is preload. That means before systole begins means that's that at the end of diastole. So preload is equal to end diastolic volume. So if end diastolic volume is high, when it can happen? When suppose in certain physiological situation, end diastolic volume can be high, like in pregnancy, total blood volume, plasma volume is high. So in such situation, the pressure volume loop will be shifted towards right. In your MCQ exam, this kind of questions will come in pregnancy. They will give you this picture and they will give you 4 options when it will happen in A, B, C, D. So in one of them will be one option which actually increases in diastolic volume. It can increase in case of, in any hyperdynamic circulation, this can occur. Suppose in thyrotoxicosis, in fever, in case of athlete, in case of pregnancy, this can happen. Okay. Now we are coming to another picture. This is like this. And this picture, again, first I draw the actual one. This is actual pressure volume loop. And now we are giving you a problem that if afterload is increased, what will happen? Now, most of you know about afterload because already 6-7 months have passed in your first year. But still, if someone has some problem in understanding afterload, let me answer. Afterload, yes, it is a load. It's actually resistance. Afterload is the resistance against which ventricle has to pump. Afterload is the resistance against which ventricle has to pump. So basically it depends on one thing, and that is afterload depends on total peripheral resistance. That means afterload gives us an idea of total peripheral resistance, which includes friction, which includes vascular smooth muscle tone, which includes atherosclerosis, which includes decrease in diameter of the lumen of vessels, which includes skeletal muscle contraction, and in this way giving pressure on the body vessels, everything. So whatever resistance, total resistance due to whatsoever reason heart has to overcome to push blood through, to push blood forward, is known as afterload. Now one scenario, one scenario where afterload is increased, what will happen to this curve? Now this curve, you will see afterload has increased, means what? The pressure will be increased. So the final EDV here, isovolumetric pressure, that will be increased and heart will pump, but the effective cardiac output will be low, stroke volume will be low because extra resistance it has to work upon. So volume which goes out, the total ejection will be low. So this will be up and half, pressure increase, volume low. That happens in afterload. In case of afterload increase, where afterload can increase, yes, suppose sympathetic overactivity, there afterload can increase. Sympathetic overactivity, stress, there afterload can increase. Atherosclerosis, there afterload can increase. Okay, so these are the two scenarios where all this can occur. There are many more other scenarios also. If contractility improves, what will happen? Suppose cardiac contractility improves, then what will happen? Suppose this is the normal curve and contractility, I'm giving you this thing, contractility that has increased. So what will happen to this? In that case, suppose contractility has increased, so end diastolic volume will remain the same. End diastolic volume will remain the same because it has nothing to do with contraction, it has to do with relaxation. But end systolic volume will be lower because ejection will be more. So basically here it will be a left shift. It will be a new end systolic volume prime, which we shall get over here. This is due to in case of increased contractility. We can see it in, in athletes, we can see it in sympathetic overdrive, we can see it in if, you take some adrenergic medication. In all these cases, this can happen. Okay, so in this way, in your exam, they will give you various situations and you have to jot it down properly. You have to zero on in which kind of physiological adaptation they are talking about. Are they talking about increased contractility? Are they talking about increased preload? Are they talking about increased afterload? That you need to know. So before we move on, let me summarize preload, afterload, and contractility a little bit. At the same time, few other definitions which are extremely essential to understand. Otherwise, sometimes we have seen that everything we have finished, but people or students still lack concept of cardiac output. They can't say in exam just simple thing. They know everything, even cardiac regulation they have marked up. Maybe some of them have good concept. Simple thing, cardiac index, cardiac output they can't attach. So that's why preload, afterload, you can be easily, one person can be felt under tremendous pressure in exam if your basic things are not clear, because most of the time examiners just ask you basics. If you can't answer those basics, they won't propagate the exam. They will just stop your exam. They will simply fail you. So basic things first. Okay, so preload, once again, let me summarize. Preload is a misnomer. It's no load but volume, and it's a volume of blood that is present in ventricle before ventricle starts contracting. Preload, and it is equivalent to end diastolic volume. So preload gives us an idea of total blood volume in body, at the same time relaxation capacity of ventricle, at the same time ventricular diastolic function, dysfunction, everything. Afterload, it's load, it's resistance. It's the total resistance against which ventricle has to pump so that it can pump blood in the forward direction. That is afterload. Contractility, it's an intrinsic property of cardiac muscle. That means it gives us an idea how forcefully cardiac muscle can be shortened, how much force cardiac muscles contraction can generate. If more force can be generated, that means more blood will be ejected. If less force can be generated, that means less cardiac output will be there, less blood will be generated, less blood flow will be generated. Got it? Now, certain other ideas. First is the stroke volume that you should need to know. That is volume of blood ejected by ventricle per stroke or per contraction. That is the stroke volume. So individual contraction leads to ejection of some amount of blood, some volume of blood. That is the stroke volume. Apart from that, इंडिविजुअल कंट्रक्शन इजेक्शन जितना होता है, जो इजेक्शन happens in individual contraction is stroke volume. So in a minute, the total stroke is known as the cardiac output. So cardiac output is stroke volume into heart rate. HR means heart rate. So individual contraction, total number of contraction, because in each heartbeat one contraction happens, that becomes cardiac output. So normally this cardiac output is total volume of blood that is ejected by heart in 1 minute. That is cardiac output. Now remember, cardiac output approximately for male adult it is 5 liter. However, 5 liter per minute definitely. So 5 liter. But however, this is again a mean value, average value, and it changes from person to person depending on his build, muscle capacity, athletics or not, gender, age, whether any disease is there or not. Everything actually can change the cardiac output. And lastly, one important thing is there, that is the cardiac index. Cardiac index is another thing. The build will be standardized. Suppose a very big rock from WWE. He has a very big frame. Suppose for a very big frame, if someone rock might have the 7 liter, 8 liter, 9 liter kind of cardiac output, and we becoming a smaller frame, we can have maybe 4.5 liter. We will be very much sorry for this, but no room for any sorrow. We can standardize this cardiac output standardized by body surface area is known as cardiac index. So basically cardiac index is equal to cardiac output divided by body surface area, which is given in meter square. So normally in maximum books it is written body surface area is 1.5. They have taken as 1.52 or something. So 5 by 1.52, it comes around 3 point something. So you are a better mathematician than me, so you can do it much better. But remember, there what is important, this is liter per minute and this is meter square. The this one is important, the unit is important. This always comes in AIMS and other institution, in NEET PG, in FMG. This has appeared many times. Even you may be asked to give this cardiac index thing, cardiac index unit in exam or in Viva. Okay, so we are here. Let us summarize. Let me check a little bit any query. You can send queries for the people who have joined later. For them, I can say that you just keep your Android app, DNA app on portrait mode. Below the video there you will see one box where enter your query, section or column is given. There you can ask relevant questions to me. The people from last session have asked a lot of questions. People who have joined later, they can ask us relevant questions regarding all these things. Okay, so before we move on, today we have another 10 to 15 minutes left today. So rather than moving on to completely new part, let us discuss a little bit about S1, S2, and I will also start S3, S4. And someone has just clicked one question to me also regarding this S3 and S4. Yes, I shall try to answer S3 and S4, include them if time permits today. So S1, the heart sounds we are asking. So first time in our class, or in many classes, as far experience told me, whenever we ask some people about how many heart sounds do you know, they say lub and dub, kind of this animalistic kind of answer. Basically this is not actually welcome. You are in MBBS and you have to know the professional jargons. So this is first heart sound and second heart sound. On abbreviation it is S1 and S2. The reason or the cause behind S1 formation and S2 formation: S1 is formed due to closure of mitral valve and closure of tricuspid valve. S2 is caused due to closure of aortic valve and closure of pulmonary valve. Now, mostly what happens, a little while ago, and also in the last step we told that whenever two sounds are close enough, so close that you cannot differentiate them as two different sounds, they will feel like single sound. That happens in terms of S1. Mitral closure and tricuspid closure happens very close, so it seems like single sound. Aortic closure, pulmonary closure is a little different. There is a gap between them. And not only that, during inspiration, if a patient takes a lot of air inside during deep inspiration, aortic valve or aortic closure and pulmonary closure, they happen at a larger gap. So during deep inspiration, remember, during deep inspiration, A2P2 gap accentuates, means increases, accentuates A2P2 gap. So this is known as physiological accentuation of S2 splitting. Once again, let me explain this thoroughly. If we look at S1, mitral and tricuspid, they both occur almost at the same time, or at least which is perceivable by our ear. Aortic and pulmonary, they occur at a distance. Why? Because aortic happens from left heart side, pulmonary happens from the right heart side. Left heart side is a high pressure zone, right heart side is a low pressure zone. So definitely there is a pressure gradient between left side and right side. Now in left ventricular outflow, as the pressure of systemic circulation, it is dealing with the systemic circulation, as the pressure in aortic zone is quickly gets up to a higher zone, aortic valve closes earlier. Once again, left ventricle deals with high pressure zone. That means aorta deals with high pressure circulation. That means aortic pressure quickly reaches higher. That means aortic pressure quickly becomes more than left ventricular pressure. So aortic valve closure occurs quickly, even in normal situation. Right side deals with low pressure zone. Pulmonary trunk deals with low pressure zone. Pulmonary artery or pulmonary trunk pressure reaches high pressure later. So pulmonary valve closure becomes or happens later. So already A2 and P2 contains a gap, and this is known as split. This split is physiologically present. It's not any disease. It's just due to difference resistance, difference pressure into different circulation. So this is known as S2 split. Now during deep inspiration, S2 split even accentuates, that means increases. During inspiration, A2 occurs earlier, P2 occurs later. A2 P2 gap increases. So instead of 1 second heart sound, 2 second heart sounds as sounds. 2 seconds heart sounds as heard. How that is possible? Let us discuss this. Now this is the condition of our lungs and heart, and our heart over here. During inspiration, more air, definitely more air, and diaphragm going a little low. So during inspiration, chest volume increases. Pressure on heart will increase, but predominantly that will increase on left heart, because left side is already under more pressure. Lungs are keep giving more pressure to left side. So pressure on heart or pressure on left heart will increase in inspiration. You may ask me what will happen to pressure on right heart? Lungs getting bigger? Definitely. They will give pressure to right heart? Definitely. But right heart is already under lower pressure. Okay. Plus, lungs getting big means all the pulmonary capillaries who are directly connected to pulmonary trunk, they are also getting big. Their volume became bigger. Their capacitance getting bigger. So their resistance is falling down. Since the whole right system is connected with the right side and also with the left side, whole right system is connected with the pulmonary side. As pulmonary vascular pressure is dropping down, right side heart will still be under lower pressure. Since the left-sided heart is connected to the systemic circulation, remember we are talking about outflow, right-sided outflow connected to pulmonary circuit which has lower pressure, and now the pressure is even decreasing because volume is increasing as per Boyle's law. So right side will have comparatively lower pressure, and left side, as it is under more pressure, as it is under more, it is getting squeezed in between two bigger lungs. So left side will be under higher pressure. So ultimate thing, left heart pressure will be much higher. So aortic zone will attain much higher pressure and aortic valve will close much earlier. Right heart pressure will still be low. Right heart pressure will still be low, comparatively low, because the outflow tract is connected with low pressure pulmonary system, and whole pulmonary system volume is increasing. Therefore, as per Boyle's law, during inspiration, during extra volume generation, pressure falls down. So right heart pressure will still be low. So therefore, pulmonary tract will continue to receive blood a little, in a little delayed manner, and pulmonary valve will close later. So already there was a split because of the function. So A2 P2, already there is a split during inspiration. Due to this reason, A2 occurs earlier. Due to this reason, P2 occurs later. So there is an accentuation. So let me explain even in a shorter nutshell right now. Two sounds. If these two sounds occur close enough that our ears cannot decipher whether they are two different sounds or single sound, then we take it as a single sound. Happens in terms of mitral and tricuspid valve. You may ask why right side, left side, but the issue is atria is a very thin walled chamber. Not much pressure difference is there between right atria and left atria. So this pressure gradient between side by side pressure gradient is not there. So therefore this M1 and T1 occurs almost at the same time. Comes to ventricle. Left ventricle is 7 times thicker than right ventricle. Left ventricular outflow tract is connected to aorta. Aorta is connected to systemic circulation, which is already high pressure circulation. So left side is already under 8 to 10 times more pressure than right side. Now comes to inspiration. Chest, lungs, they are getting more volume. They are getting more air. As per Boyle's law, if there is more volume, pressure falls down. So what is happening actually? More volume in the lungs zone, that means lungs will squeeze the heart. Left side is already under severe pressure. Now it is getting squeezed. It will comparatively have more pressure generation. Right side is also getting squeezed, but already initially its pressure was lower than left side. Again, right side is connected to lungs. Right side outflow tract is connected to lungs. If right side is squeezed due to increased flow, some of the blood will easily go into right side circulation, pulmonary circulation, where pressure is low, which means it will dissipate the pressure. So increase of pressure in right side, rate of increase of pressure in right side of heart will be lower than the rate of increase of pressure on the left side of the heart. So therefore, left side will deal with more pressure with earlier closure of systole, earlier aortic closure, and right side will deal with left pressure. So systole will continue longer. So P2, pulmonary closure, will occur later. So that's the the split and accentuation. And quickly, two more things we are coming. One is S3, the other is S4. You can ask me questions, we shall discuss it also on the next and subsequent classes. S3 occurs in early diastole when rapid ventricular filling occurs. So during rapid ventricular filling, S3 occurs. It can be physiological. That means it can be present in a normal person. What are the physiological reasons of S3? One is pregnancy. Yes, this is a physiological. Then it can be present in athletes. Yes, S3 can be present. That is also physiological. It can be present in males below 30. It doesn't mean, I do not mean that all the males below 30 have S3. No. But if you find S3 in a male below 30 years and he doesn't complain as such of any other symptom, you can say this is this is okay, this is normal, this happens. And it can also be found in case of infants. This is the physiological. In case of pathological, S3 can be found in case of hypertension. S3 can be found in case of heart failure due to various reasons. Okay, so these are the pathological. Gallop rhythm, there is one thing also, gallop rhythm you will learn later, where you see we find S3 which occurs due to heart failure. Okay, so this is also pathological reasons. Now coming back to S4, I'm making it a little bit minimized at the same time so that you can take note. S4 is the fourth heart sound. And remember, S4 is always pathological. S3 can be pathological, can be physiological. S4 is always pathological. And S4 is the only atrial heart sound. All the other sounds are either due to ventricle or due to valve closure. It is only sound which is atrial. It happens during the second rapid filling phase. It happens when atria has to kick against stiff ventricular wall. When atria has to kick against stiff ventricular wall, only then S3 can occur. S4 can occur. Now, what are the scenarios? It is always pathological. One example where it can be found in dilated cardiomyopathy. It can be found post myocardial infarction. In first year, you just need to know the names. Cardiomyopathy is a disease of cardiac muscles. Myo means muscle, pathy means disease. It's a disease of cardiac muscle, basically, and it can be found in hypertrophic cardiomyopathy, which is also known as HCM. So this is all about S4 and S3 in a nutshell. So basically, if you have any query, you can ask me, and I think it was mostly clear to all of you. Let me summarize what we have done today. We have started with the basic and functional anatomy with the overview of the whole subject and its implication, and how you can utilize our classes during the lockdown. I can see a lot of people have messaged me, quite a few I could answer. Some of the messages, some of the questions were actually common, so we have also discussed them. At the same time, basically, we had already discussed, and we have discussed the cardiac cycle, the approach to writing question answer in physiology, and we have discussed about the pressure volume loop, left ventricular pressure volume loop, and its applied significances, and we also discussed about the heart sounds S1, S2 especially, and also for exam purpose in a nutshell S3, S4. If you can remember all these things, and if you have a solid concept of all these things, I think it will be very easy to pass. And not only that, that is just the first step. Our major step will be to generate the concept, to retain the concept, and to apply the concept. With this, myself, Dr. Soham, physiology faculty, I am signing off for today. Wish to meet you very, very soon again and regularly. Thank you. Good night and stay safe. Wear a mask and regular hand wash. Take the usual COVID precaution. Thank you.